we have Dr. Salim from Children's Hospital Lahore, and I'm also from Children's Hospital, so we are moderating this session. And I would like to introduce Dr. Salim for a few words of introduction. Sir.
Assalamu alaikum and good evening. We are really thankful to our American colleagues for continuously contributing for academic activity in Pakistan. These academic activities are arranged from Children's Hospital Lahore along with the Association of Pediatric Surgery and our American colleague. We are really thankful to Dr. Naeem Liaquat, who are continuously contributing and helping us for arranging these activities. Today's our speaker is Richard J. Wood. He is expert in pediatric colorectal and pelvic reconstructive surgery. We are really thankful to him for his for giving us a time for this academic activity. Common cloaca is always a challenge for management for the pediatric surgeons, but actually to know the anatomy and to define the functional outcome and cosmetic outcome of the patient, we have to do the proper workup. This workup is needed for defining the anatomy of the common cloaca, and in this regard, for this this webinar is arranged. Dr. Richard J. Wood will address us and will give his expert talk on the diagnostic challenge and therapeutic management of common cloaca. Therapeutic management will be discussed in next session. Today's will be our main focus will be regarding diagnostic workup of the cloacal malformation. I request Dr. Naeem to introduce Richard J. Wood.
Thank you, sir. Richard Wood is currently the Chief of Pediatric Colorectal and Pelvic Reconstruction Surgery at Nationwide Children's Hospital in Columbus, Ohio. He is an Associate Professor of Surgery at the Ohio State University College of Medicine. He was trained in South Africa, United Kingdom, and then United States. His area of clinical and research interests are anorectal malformation, Hirschsprung disease, and cloacal malformations. He has done extensive research on colorectal outcomes and quality of life. He has presented more than 130 national and international presentations and has published more than 120 peer-reviewed manuscripts. He is also author of more than 25 textbook chapters. So, Richard, can you please start your presentation without any delay?
So, Dr. Naeem, just a request for the participants that they should keep the mics muted at all time to avoid any interruption. And if anyone has a query, he can type in chat, or he can ask, someone can ask question after the presentation. Thank you. So over to you, Dr. Richard.
Okay, well, thank you very much for having me. It's an honor to be here. And I first of all just wanted to thank Naeem, who's been such a good friend. And it's been an absolute pleasure having him here in Columbus. He asks fantastic questions and is always inquiring and working on how to do things better. So it's been an absolute pleasure having Naeem here, and I appreciate him facilitating setting up today's meeting. So I just wanted to talk a little bit about, we were going to talk about the preoperative workup of cloaca today. And I think if we're all honest, very few patients are actually diagnosed antenatally with cloaca. Even in the United States, it's very rare. Certainly in South Africa, where I worked before this, that was even more rare. And I'm sure Pakistan is more like where I worked in South Africa in many ways. And so, you know, as much as people like to talk about this at meetings, I don't think it really is very commonly seen. This just shows a fetal MRI. And if you look at my cursor, you can see the sort of hydrocolpos here. But I think that's a very unusual thing. So generally, we're dealing with the patient that's been born, and it's an unexpected finding that the patient has a cloacal malformation. So, you know, sometimes it can be a little bit overwhelming to try and work out what we're dealing with. So we try to simplify the way we look at children with anorectal malformations a little bit. And if it's a female patient with no visible anus, the simplest way to do things is just to count the number of orifices or holes you see on the perineum. And that really allows you to kind of try and order your thoughts, especially for the trainees. Sometimes this can be quite overwhelming, but if we focus on the number of holes on the perineum, it can help focus our thoughts. So today's talk, we're really going to be dealing with cloacal malformations where there's a single perineal orifice. We will talk a little bit about the initial management, and I'll get onto that in a little second. We usually start off with cloacas with doing a renal and pelvic ultrasound on day one, because it's really key to working out if this is a patient who has a hydrocolpos and hydronephrosis, or if there's no hydrocolpos. If there's hydrocolpos, then that adds an extra dimension to the treatment, and we'll get onto that in a little second. It is true to say that all anorectal malformation patients will need a workup for Vactrol. I think most of us have done Vactrol workups in the past, so I'm not going to take too much time today talking about Vactrol workup. We can touch on that if people have questions, but I really felt like today we just focus on the cloacal initial management and workup and planning for reconstruction, if that's okay. So the first key bit, I think, is to make the diagnosis. And the diagnosis is made by doing a good clinical exam with good lighting. If you just look at the patient like this, you really can't see very much. And so the key is to actually lift the labia up and out, and that allows you to see and confirm that there is in fact just one perineal orifice. And if that's what you find, then you know you're dealing with a cloacal malformation. If there is no anus, we don't need to be concerned about DSD or disorders of sexual differentiation, because we don't see that happening in patients with cloaca and anorectal malformation. So in our practice, we don't do any genetic workup to look for patients to see that they have normal chromosomes in a patient who has a cloaca. And I think that's an important point to make. Now, a child with a normal anus and a urogenital sinus, that's a different story. But for cloaca, we don't really need to do that workup, in our opinion. So good lighting, a good clinical exam, and moving the labia apart in order to be able to really see the perineum is the key first step to examining these patients. I just wanted to talk a little bit about the clinical exam in little girls with anorectal malformations, because I think it's quite important. And the landmark that we use really is the hymenal tissue. So in a normal child, the urethra lies outside the hymenal tissue in the front, and the anus lies outside the hymenal tissue at the back. Can you guys see my cursor of my mouse?
Yep.
Yeah.
Okay, perfect. So if the urethra lies within the hymenal canal, then it's a hypospatic urethra, okay? And if that hypospatic urethra is more than 1 centimeter, it just generally is classified as a short common channel cloaca. If the hypospatic urethra is within the hymen, but shorter than that, then it depends on what's going on at the back as to whether we're dealing with a cloaca. If the rectal opening or anal opening is in the muscle complex, it's obviously normal. If it's in this area here, it's a perineal fistula. If it's in here, it's a fourchette fistula. If it's here, it's a vestibular fistula. And if it's inside the hymen or the hymen's deficient, it's a rectovaginal fistula. Now, if the rectovaginal fistula is associated with a hypospatic urethra, it becomes a cloacal malformation. And I think having that clear in your mind when you're examining these children really helps us to all talk about the same things, because sometimes there can be a little bit of confusion as to what we're looking at. But I think a good clinical exam, and sometimes it's difficult to get that information just in the ward or in the ICU. So sometimes doing an exam under anesthetic while you're performing the colostomy is very, very helpful to make those decisions. So sometimes we can see strange variants of cloacal malformation. And when you look at this patient's image, you can think, well, I wonder what I'm dealing with here. And, you know, is this a standard cloaca? Is this a cloacal exstrophy? Could it be a covered extrophy, or could it be a posterior cloaca? So if we look at this image here, there are a number of things that strike me when I look at it. The first is that the opening is quite large. This is a larger opening than we generally see with a cloacal malformation, a standard one. Secondly, if we look here, we can see a ridge here and a ridge here. And that will denote that the pubic symphysis is not fused. So where we see a larger opening in the area of where we think the urethra and vagina should be, with a splayed pubic symphysis, that's almost certainly a covered cloacal extrophy. And that we would deal with quite differently. So just be aware that there are variants, and that's a variant one should be aware of. Splayed symphysis, large opening, anteriorly located would be a covered extrophy. The next one here, we look at this patient and we see here's the clitoral structures, and we see a single opening in the area of where the rectum should be. And this would be a posterior cloacal variant in this particular patient. And so one just needs to be aware that when you're doing your clinical exam, you have your standard cloaca, which is a single orifice in the area of the clitoris. You can have a covered extrophy variant, which looks like the one we've just seen. And we can have a posterior variant, which is the one we're looking at now. We can also sometimes see other things. So we can see these fatty deposits on the perineum. And in this case, we're dealing with a lipoma, but obviously other things can be found. And so one should have a differential diagnosis in these cases. And the other thing which we definitely see is the presence of hemangiomas in the perineum. And these can lead to a lot of bleeding at the time of reconstruction. So in our practice, we would give patients propranolol to reduce the hemangioma and then confirm that it's gone with an MRI prior to doing reconstruction. Otherwise, you can get into a lot of bleeding, which is unnecessary. And so we would delay surgery until we'd got that under control. So if we now get on to our patient that's been born, that's going to be examined in the neonatal ICU. And the one thing we said that we would have to look at in the first 24 hours is, does the child have hydrocolpos? And that can be defined as an abdominal mass, as we can see drawn on this patient's tummy, or on this x-ray, we see there's a large filling defect in the middle of the belly where there's no bowel gas. And this indicates that the patient has a soft tissue swelling. And then the ultrasound will confirm that the soft tissue swelling is in fact a hydrocolpos. And this is important to diagnose because it'll affect our care in the first several hours of treatment. Sometimes this can be extremely large, as it is in this case, and the baby may even struggle to breathe because of the size of the hydrocolpos. So once we've diagnosed the hydrocolpos with our ultrasound, which we see here, then the next question we have to ask ourselves is this a hydrocolpos in isolation? Or is the hydrocolpos in fact causing an obstruction to the kidney, as we see on the right-hand panel, where we see a hydronephrosis as well? And if the hydrocolpos is causing hydronephrosis, then it must be managed, because if we don't manage it, it's going to damage the kidneys. And so then the next question we have is, well, how do we manage the hydrocolpos? Now, obviously, we're in a situation now where we've got to make decisions relatively quickly. We've got a newborn baby, they've got a cloacal malformation, they've got a hydrocolpos, and we're trying to work out when are we going to do the colostomy, because we have to divert the stool, and what are we going to do about the hydrocolpos? Now, there's a traditional approach, and there's some other ways of doing it, and I just wanted to explain a little bit about the anatomy, and then we can talk more about what the approaches might be. So if we're looking with a cystoscope, or if we're passing a catheter, if we look here, we can see that the catheter will almost always preferentially go into the vagina or vaginas. Now, I'm going to illustrate that further by showing you a cystoscopy of a patient with a cloaca. And if we look here, when we go in, we're looking straight into the vagina. We're not looking into the urethra. That's the rectal fistula at the bottom. We look straight into the vagina. In this case, the patient has a septum with the cervix on either side higher up. Now, to get into the urethra is actually quite difficult. We have to drop our hand with a scope right down and then look on the roof of the common channel, and there we'll find the urethra into the bladder. And the reason I show that video is to say that when you catheterize the perineum with a tube, you will almost always preferentially go into the vagina. It's actually very unusual to go into the bladder, and it's very unusual to go into the rectum. And I think that's an important point to make, because when we start talking about how do we drain the hydrocolpos, we must remember that if we pass a catheter through the perineum, we will almost always go into the vagina and the hydrocolpos. And this is something which we can definitely check using ultrasound. So the question then becomes, if you have a newborn baby with cloaca who has a hydrocolpos, how are you going to deal with it? Are you going to do a vaginostomy, surgical vaginostomy at the time of your colostomy? Are you going to do intermittent catheterization of the perineum, or are you going to do interventional radiology drainage or surgical drainage with a tube? Because ultimately that's a decision you have to make within the first 24 hours of seeing this patient, because you're going to be taking them to theater to perform a colostomy, and you want to be organized in your decision making to know, well, am I going to do a colostomy, a vaginostomy now or not? So let's look at the evidence and the data behind CRC versus vaginostomy for patients with cloaca. Those are the options. You know, you can either set up a vaginostomy tube with your colostomy there, or you can set it up on the other side, and there are various catheters that you can use to drain it. So the reality is, in the literature, there's no real evidence to suggest the advantage of one over the other, but it is definitely less invasive to do intermittent catheterization of the perineum. You're not doing an extra procedure, and you do get complications from doing vaginostomies. In addition, if you're leaving a tube in, that tube can either fall out, which can then cause trouble, or it can become encrusted with like stone-like formation, which can then be a place for infection to hide. And there's some evidence that you get very resistant bacteria growing in the urine in those children, which can lead to kidney damage. So with no real advantage to preserving kidneys by doing a vaginostomy, it has become our practice here in Columbus to do intermittent catheterization. And we do intermittent catheterization from day one. We confirm the tubes in position with ultrasound. And we do follow-up ultrasounds to make sure that we're decompressing the hydrocolpos and decompressing the kidneys. And I must be honest and say that it's been probably 4 or 5 years since I did a vaginostomy, and we have quite a large cohort of cloaca patients here. We've been able to successfully drain them with CRC. Now, I understand that's not for every patient, and if follow-up is going to be a problem, getting children back to confirm with ultrasound, or parents struggle to do the CRC, you may find doing a vaginostomy is more helpful. But I certainly wanted to raise that it is an option to do intermittent catheterization, and therefore one doesn't need to always do a vaginostomy at the time of making your colostomy. And we can certainly go through that in the question section later on if people have more questions about that. If you do a vaginostomy and the patient has a septum, I think it is important to remove a piece of the septum so that you can drain both sides of the vaginas, or both vaginas, through the same orifice. Because I think if you don't do that, then you make it possible to have done an operation to drain the hydrocolpos and then only drain one side. And if you only drain one side, you only drain one kidney, and the patient can still land up with damage to their kidneys, even though you've gone to the trouble of doing the surgery to drain the vaginas. And here we can see, placing the vaginostomy in the anterior wall. There your uterus is coming in, your cervixes will be over here. So you want to do it away from the cervix, not to damage the cervix, and removing a small portion of the septum, which then allows both sides to drain through the same orifice. So how do we follow up our hydrocolpus patients? Well, we follow them up with recurrent ultrasounds. We start off by doing them once a week when they're little babies in the NICU to confirm that we're making progress. Once they go home and we've decompressed the bladder, we're able to extend that to once a month. And once they're stable at about 3 or 4 months, you can extend that out further. We usually do the reconstruction somewhere between 6 to 9 months. So we want to keep making sure that we're draining the vagina and the kidneys. And most important thing is obviously the kidneys prior to doing the reconstruction. So what do you do in a patient where you've drained the vagina is decompressed, and the patient still has hydronephrosis? Well, the answer is you need to then address the urinary system in isolation, because the problem therefore cannot be distal obstruction to the ureters, which is caused by the hydrocolpus. So in some cases, you may choose to do a vesicostomy. It may help, excuse me. Otherwise, you may have to do a ureterostomy or a nephrostomy to drain the kidney. But I think this is why follow-up ultrasound is so important, because you can do a vaginostomy, but you shouldn't assume that now that I've done a vaginostomy, your job's finished. Remember, the job that we are trying to achieve is to adequately drain the kidneys effectively. So we can't stop working until the kidneys are decompressed. So first step, drain the vagina, either with vaginostomy or CRC. If that doesn't decompress the kidneys, drain the bladder. And that could be just by leaving it in an indwelling catheter for a couple of days and seeing if that helps. And if that does, you may choose to do a vesicostomy. And if the vesicostomy doesn't help, or an indwelling catheter doesn't help, then you may have to do either ureterostomies or nephrostomies, depending on what you need to do. But again, our job is to keep working until the kidneys are decompressed. So obviously the next step is to drain the stool, and that can either be done at the same time of the vaginostomy if you're choosing to do a vaginostomy, or if you're not going to do a vaginostomy and you're going to use CRC, then you'll just be doing a colostomy. I think placement of the colostomy is very important. I understand that many of us have seen patients with long delays to get into the hospital, which can obviously complicate things. The colon can become very distended. And sometimes when I was working in Cape Town, we used to put in a purse string and put a catheter in through the purse string and suction out meconium first so that we could actually mobilize the colon because it's so friable, and then only get it out the abdomen once we've got it out. I think the other important thing to note is that when it's very dilated like this, it can twist. So you want to be very, very careful that you know what's proximal and what's distal. But if you do have the proximal and distal sorted out, then I would advocate that we go as high as possible on the sigmoid colon, and even sometimes mobilize the white line of Tolt on the descending colon, so we get the corner of descending colon to sigmoid as our colostomy, and that helps to prevent prolapse, and it also gives us plenty of length for our subsequent reconstruction, which, if it's a high cloaca, can be really important. We don't personally advocate for doing transverse colostomies in cloaca. I know that was always Dr. Hendren's practice, but it's very, very difficult to image patients through a transverse colostomy. And in addition, they absorb a lot of urine in the colon distal to the transverse colostomy, which can make these children acidotic. And this can mean that they don't put on weight and grow well. So because of those reasons of limited imaging and acidosis and poor growth, we do not advocate for transverse colostomies, but rather proximal sigmoid colostomies. But again, that may be something we can discuss further in the question and answers at the end. So important to mark your landmarks to make sure you know what places you want to avoid, because if you're wanting to put on a bag, you want to put on a bag in a place that fits. And we had a challenge yesterday dealing with a cloacal extrophy patient of where to put the stoma because the child was only 1.5 kilograms. And so marking your landmarks beforehand and making sure we put our stomas in a good position that we can bag is a really important thing to do. All right, and there are various ways of doing this. I personally like not having an incision all the way up to the working stoma, either using laparoscopy or making this my working incision and making a separate hole for the working stoma. That way you don't have an incision right up to your stoma that's going to have stool coming out. And I think that can make your wound healing much better afterwards. So if the patient's very distended, then obviously laparoscopy is not an option. So you may be in this position. If you land up doing a vaginostomy at the same time, you may choose to do a midline laparotomy. Put the vaginostomy over here on the right-hand side, and then just making 2 holes like this situation, one for your mucus fissure and one for your working stoma. And that way you avoid the traditional incision between them, which can be a real problem from a wound healing perspective, especially if your patient's presented late or is malnourished or has other underlying conditions that may lead to increased risk of wound infection. So the next steps I would suggest would be to think about reconstruction. It's very important in the interleading months to make sure that the patient is growing and putting on weight. We may need to supplement patients to help them put on weight better with nutrition. Another thing which we do a lot is checking the urinary sodium on patients to make sure that they are not losing salt in their stomas. And if they are, we supplement them with sodium chloride to help them to gain weight. Because if your sodium levels drop, you can struggle to absorb glucose from your diet. We also need to, of course, make sure that the colostomy is draining well, and we need to make sure that the hydrocolpos is remaining decompressed. If those things are all happening, then we can think about planning our reconstruction somewhere between 4 and 12 months of age. When we talk about the reconstructive planning, we talk about an examination under anesthetic, and a cystovaginoscopy and EUA, and we do that at the time just before reconstruction. We don't advocate for doing cystoscopy when the baby's born. We've seen a number of children have injuries to their common channel, which has caused long-term trouble by having cystoscopy done in the newborn period. We don't believe it changes your management. And so that's why we don't do it at that time, and we rather do it just prior to reconstruction. That way you get the information you need when the patient's a little bit bigger and a little bit less chance of damaging the structures. We also do a cloacagram, which is an image, and I'll show you some examples just now, which allows us to understand the 3-dimensional anatomy that we're dealing with. And then we use a multidisciplinary team of colorectal surgeons, pediatric urologists, and pediatric gynecologists to plan surgery. And as I said before, we'll do it somewhere between 4 and 12 months of age, depending on the patient's underlying general medical condition. But generally, most patients get the reconstruction above 6 months. So we have a big team, and we're very blessed to have a big team. I don't think you need to have a big team. As long as you have a team where people you can trust and work with, and you work well together, and no one brings their ego to work, then I think you can do well. Even with big or small teams, the same things are important. So next question is, well, what are the goals of the assessment? What information are we trying to get before we can understand how best to operate on this patient? Because, you know, if we just examine who knows what we work out. If we have a checklist of information we need to get from our examination, I think it makes it much easier for us to work out what we're going to do. So we need to know the length of the common channel. We need to know the length of the urethra, and I'll explain a bit more what I mean by that. We need to know the length of the vagina and the vagina's anatomy and orientation to the common channel and the rectum. We need to know the location of the rectum, and for this we use the PC line, which links the pubis to the coccyx, which is from the old ARM classification like wing spread. And then we also need to know the distal colonic anatomy. How much colon do we have from our mucus fistula that will allow us to do an effective pull-through? If we can get all that information from our assessment, then it makes it possible for us to understand how difficult this is going to be to reconstruct, what techniques to use, and set us up to be successful. So I'm just going to show this again because I think it's important. So you're going to do a scope and you're going to have a look and see where all the structures are. And once you've seen where all the structures are, we're going to measure the length of the vagina, the length of the urethra, the length of the common channel, and identify where all the structures are. And then in our situation, we're going to put some catheters into the patient, and we're going to send the patient to radiology, and they will get us some imaging. Okay, and we do that with the patient still asleep, so that we can get good quality imaging without the kid kicking around and kicking out the catheters and that sort of thing. Okay, so this is a two-dimensional image of a patient with a cloaca. We can see here's the bladder. We can see here's the rectum. Yes, I did say the rectum. And here's the vagina. Unfortunately, the patients don't always read the textbooks. And sometimes the rectum actually implants anterior to the vagina. We see this not infrequently, I would say in about 20% of our patients. It has significant implications on your reconstruction. Because if you come in the back here, you're not going to find the rectum as your first structure. So it's really, really important that you know this information, because it may mean that you will start off in the abdomen to find the rectum first, and then have a totally different approach for how you're going to deal with the vagina. So it's really important we know this information. And it's also important that we discuss what structures we're measuring. So if we look here, you can see I've marked a structure with a yellow dotted line. And then I've marked another structure here with a yellow dotted line. So here we're measuring the common channel from the outside of the patient to where the three structures meet. And here we're measuring the urethra, which is the distance between the common channel and the bladder neck. And that's a really important thing to get in our minds. So common channel, urethra. And I'll go into that in a bit more detail in a second. It's also really important that we think about the angles that we look at things in life. So here's an example from nature, that if we look at things in one way, we get some information. If we look in another way, we get a lot of other information. Now, I don't know if any of you guys know the royal family, but the same thing applies, right? Prince William looks like he's being very rude in one picture and not rude at all in another picture. And the reason I show this is not to be not serious in an academic meeting, but to show us that in life, we need to look at things from multiple angles, especially complicated things, so we can truly understand what we're dealing with. Because if we don't understand what we're dealing with, we can completely mess up the reconstruction by thinking that this structure here is the rectum, and therefore getting the reconstruction completely wrong. Because the patient does not want the rectum pulled through behind the urethra and the vagina pulled through in the anal canal, in their muscle complex. So getting good information really helps us. And that's why we do these three-dimensional structures here. And this is a rotational image showing you a reconstruction. And you don't need fancy equipment to do this. We just need the normal C-arm that you use to do an angiogram, and most hospitals have a C-arm for angiograms. And then we have the software programs, and we can share those via Dr. Naeem to help you to do this kind of imaging in your own hospital. So we believe 3D reconstructed imaging is really important. And then once you've done the reconstruction, you can make it look pretty if you want to. And here, obviously, it makes it easier to see. But being able to look at this and be able to see the rectums entering high, you have 2 vaginas, and that this patient has bilateral reflux, and where the ureters are very important in your reconstructive planning. You can actually make images like this as well, which you can manipulate in a computer and move around and look at different angles. And this allows you to really understand how all the structures enter and what your best approach is going to be. So for me, this works about as well as 3D printing without the additional cost of doing 3D printing because it's very expensive. So does this stuff matter? And we weren't sure. So one of my colleagues did a study here, and we published this in Journal of Digital Imaging. And what we did was we took a bunch of trainees and consultant surgeons, and we showed them different types of images. And by showing them different types of images, we were trying to work out, did they understand the anatomy better if we showed them more complex imaging? So we showed them 2D images, 3D images, 3D reconstructed images that they could interact with, and 3D printed models. And we then examined how well they understood the anatomy. And what became clear was, if we look in this table, between the trainees and the surgeons, is that both groups understood the anatomy much better as we used more complicated imaging. It's also clear that the consultants weren't much better than the trainees. And that shows you that these are rare conditions and that everybody finds them difficult to examine, except for if you do like 20 or 30 of these a year. And so everyone can benefit from looking at these more complicated images. So just to go back to what we were talking about before, this is a patient where they have a long urethra and a very short common channel, right? Here's the vagina, here's the rectum, there's a long urethra, and the common channel here is extremely short. Here's an example of a patient with a short common channel around 2.5 to 3 centimeters and an adequate urethra, a good urethra of more than 1.5 centimeters. And here's a patient with a longer common channel and a urethra, which is not bad, but a longer common channel. And you can see how the anatomy of these 3 patients is different. Longer urethra, good urethra, getting shorter urethra as the common channel gets longer. So in the old days, all we used to talk about was the length of the common channel, right? We never talked about the length of the urethra, and I'm going to explain now why we feel like the length of the urethra is really important. So the length of the urethra is the length from the bladder neck to the common channel, as we already said. This is a UG sinus patient, not a cloaca, but the same anatomy applies. And so we were struck when maybe 5 or 6, no, longer than that, about 8 years ago, 7 years ago, that we were seeing a lot of patients coming to see us who'd had a cloaca repair that were incontinent. They had no continence at all. And we were concerned that the urethra was being pulled down to the perineum and it was too short and the patients didn't have any capacity to hold urine. So we looked at the urogenital sinus literature and we found that the urethral length was the most important factor in determining the reconstructive options. And that had been around since 2005. However, there was no discussion on urethral length in cloaca, and that really bothered us. So surgical planning in cloaca, we hadn't looked at the urethra at all. We were just looking at the common channel. So we were trying to work out, well, why is the urethral length important? And what is the functional perspective of this urethral length? And so in normal anatomy, the bladder neck lies above the urogenital diaphragm, as we can see here. So the bladder neck is above the urogenital diaphragm. And so what we wanted to work out was, what length did the urethra need to be to land it above the urogenital diaphragm? And so therefore it was important to know what was the normal urethral length in a little girl. So we wanted to know what the normal urethral length was in small children, and we wanted to know, how does this change over time? And we wanted to know, does the 1.5 centimeters length that they use in UG sinus surgery apply? And is it really validated? So we did a study here in Columbus. We looked at 141 patients. 91 of them had good imaging, and we divided them into 3 groups, between 6 and 12 months, 12 and 24 months, and 24 and 36 months. And we plotted the length of their urethras on a scatter chart, as you can see here. And what we were able to see is that the vast majority of patients had a urethral length of more than 1.5 centimeters. Therefore, if we know embryologically that the bladder neck must be above the urogenital diaphragm in a normal child, then if we made our urethra 1.5 centimeters minimum in a cloaca, then we would have a normal urethral length and therefore likely have children who were continent. And so we were able to, in this case, confirm that A, between the ages of 6 months and 3 years, there's very little growth in the length of the urethra in little girls. So it doesn't matter if the child's 9 months old, 12 months old, or 24 months old, 1.5 centimeters seems to apply. And then we also found that if we used that, we would land up in the good position. And we published that in the JPS. So if you do your examination and you find the patient has a urethral length of more than 1.5 centimeter and a common channel length of less than 3 centimeters, then we believe that the surgery you should offer, so again, urethral length of more than 1.5, common channel of less than 3, the surgery we should offer is a total urogenital mobilization. And we're going to talk much more about the technical parts of the surgery next time, but I just wanted to make sure we understood what I meant. These pictures are difficult to necessarily always see, but I think the important point of why we think this is important, if you do a total urogenital mobilization, when you do the procedure, you split the common channel and the urethra is sewn down behind the clitoris. If you look here, this is an artist's rendition, but again, the common channel is split and the urethra is sewn down behind the clitoris. Now, if we go back to this image, if the urethra here is very short, less than 1 centimeter, then what lands up happening is the bladder neck will be sewn down here behind the clitoris. You'll have a very short urethra and a very high level of incontinence after surgery. We know this is significant because if we look at the original paper that Levitt and Pena wrote on long common channel cloacas, more than 75% of the patients were not continent for urine. Now that may be for many factors, but one of them I think, or we think, is because the patients with short urethras were getting total urogenital mobilization done. Okay. But we will deal with the technical aspects of the reconstruction, as I said, in the next webinar series, which we will announce at the end of this meeting. So what about if the urethral length is less than 1.5 centimeters? So in this situation, the urethra is short. If we do a TUM, then this part here comes down to outside, and the bladder neck then lies well below the urogenital diaphragm, and the patient's chance of being continent is extremely low. So in this situation, we want to do a urogenital separation. Now, photographs of this are difficult to show, so I'm going to show you an artist's rendition of this. And again, we're going to do this in much more detail at the next webinar. But in this situation, the rectum is separated, the vagina is separated, the common channel and urethra are repaired and covered with a fat pad, and then the whole lot are reconstructed in their normal 3 positions. So 2 fundamentally different operations. One, a total urogenital mobilization, the other, a urogenital separation. So just to go over it again, the information that we need to make those decisions is the length of the common channel. And here we can see 3 examples: short common channel, medium common channel, less than 3 centimeters with a good urethra. Here, very short urethra, long common channel. And by getting these images and getting those measurements, we can make a decision on what the next step should be. So we proposed this new algorithm, and this was done in 2017. And what we were able to show was that with preliminary results, we were able to choose the right operation without having to change our plan. At this time, there were only 50 cases. There are now 126 cases, and we still haven't had to change plan intraoperatively. So we feel like these results are getting us, these ways of planning preoperatively are helping us choose which patients are going to need to have a separation and which patients are going to need to have a mobilization. And we're going to talk about those techniques in more detail at the next meeting. What about the rectum? So it's important when we talk about the rectum that we consider what the position of the rectum is in relationship to the PC line. So the PC line lies here from the bottom of the pubis to the coccyx. And we can see in this particular case that the rectum is way above the PC line. That means if we open up posterior sagittally, we're not going to find the rectum very easily. So what do we do in that situation? Well, we have to decide, are we going to be able to do a PSOB or PSOB-VUP with the TUM, or do we need a laparoscopic or open approach to first free the rectum before we do the urogenital part? And we don't believe that you have to choose both the same for the same patient. In this patient, they have an adequate urethra. They have a common channel of less than 3 centimeters. So this patient would be well suited to have a total urogenital mobilization done, but the rectum is very high. So we would advocate for starting in the abdomen, mobilizing the rectum with a laparoscope or a laparotomy. And we actually did this in a patient we did a cloaca on Monday, where the bottom was actually very short, but the rectum was very high. And so we used the laparoscope for the rectum, and we're then able to complete our reconstruction from below. What about the vagina? Well, we found that if you did a total urogenital mobilization for the patients with a common channel length of less than 3 centimeters and a urethra of more than 1.5 centimeters, the vagina will always reach the perineum. So if you stick to the rules, the vagina will always reach. However, if you're doing a urogenital separation, the vagina will not always reach. And so we did a study here trying to work out what would be the risk factors for the vagina not reaching the perineum, i.e., which patients would be likely to require a vaginal replacement as part of their reconstruction. And what we were able to find was that the only factor that really determined the need for vaginal replacement was the length of the vagina. And it was much more likely, if the vagina was short rather than long, that they would need a vaginal replacement. Now, unfortunately, you can see here that the confidence intervals in this study were crossing, and so we don't have one number for you, but we do know that if the vagina is less than 6 centimeters long, when you measure it, your chance of needing to do a vaginal replacement is higher than if it's longer than that. So unfortunately, I don't have a number for you like 5 centimeters or 6 centimeters is the cutoff, but it is a good guide that if you're doing your scope and you measure the vagina and you see that it's less than 6 centimeters, you should be prepared then that you're going to do a separation and you may need to do a vaginal replacement. So here are just some more images showing different examples of three-dimensional reconstruction that help us to make decisions. Here we can see again another example of where the vagina is posterior. And I'm just showing you that to know that it happens often enough. And then you see here your rectum has to be taken off first, and this allows you to then free up the structures. Okay, so just to go back to the algorithm states that we do a cystovaginoscopy and a 3D cloacogram. And if you need to have help with how to do a 3D cloacogram, we can work with Dr. Naeem and work to how you get you the protocol. At that point, we got to make a decision as to what the length of the common channel is and the length of the urethra. If the length of the common channel is less than 1 centimeter, we can leave the urethra alone and we can just do a vaginoplasty or an introitoplasty and a PSOB. So that we call a type 1 cloaca. If the cystovaginoscopy and cloacogram shows us that the common channel is between 1 and 3 centimeters of length, then we look at the next step is to look at the urethral length. If the urethral length is more than 1.5 centimeters, then we know we can do a total urogenital mobilization and a PSOB. If the urethral length is less than 1.5 centimeters, we need to do a separation, protectile repair, and do a PSOB. If the common channel is greater than 1.5 centimeters and the urethra is less than 1.5 centimeters, you're going to do a UG separation and a PSOB, and you may need to consider doing a vaginal replacement. If the vaginal length is shorter than 6 centimeters, your need to do that is considerably higher. The goal of this algorithm was to allow any surgeon to examine a patient with a clear set of information that they need to get so that they can know what kind of a reconstruction the patient will need and therefore how difficult this reconstruction will be. Because it might be that that surgeon feels comfortable doing a total urogenital mobilization, but does not feel comfortable doing a UG separation and may want to get a senior colleague to help them or send them to a different center where they do more cloacas and help them there. But this algorithm has allowed us to operate on multiple of these patients with not having to change our plan between TUM and separation, which is really important. There was a study done years ago where they looked at what happens if you try to do a TUM, but you're not successful. And we'll go over this in more detail at the next meeting. And in those patients, if you have to change plan from doing a mobilization to a separation, 70% of patients lost their urethra and needed to have the bladder neck closed and a vesicostomy and long-term a Mitrofanoff. In our series, which we recently published, 97% of patients were able to maintain a urethra. Put that up here, it's this paper here. We're able to show that. So we believe that doing this upfront assessment allows you to be much more successful in maintaining a good urethra and hopefully long-term maintaining good continence. So we've written a number of papers through developing these protocols, and we now have outcomes results which are showing us that the protocols work. You guys obviously have these slides. So it's now been just on an hour since we started, and I was asked to talk for an hour, so I'm going to stop here and ask if there are questions. And again, thank you again for the opportunity to talk today. This is just a view of our hospital in the city of Columbus. And then just thank you again for this opportunity and open up for questions.
Thank you, Dr. Richard Wood, for such a nice and precise presentation. So we have a few questions. One is from Dr. Fiana, and she's asking, how often does a patient need CIC for hydrocolpos? How do you guide parents to do CIC about the need, timings, interval for CIC? Do they wait until baby goes into urinary retention for CIC?
Okay, thank you very much. Those are great questions. So we usually teach the parents when the baby's in the NICU how to do it. And we can confirm that they're doing a good job with a bedside ultrasound. And we usually get the parents to do the CIC 3 times a day when they're changing, the baby's diaper. It's very quick, and most parents can learn very easily. And obviously the goal is not to let them get into retention, because generally what's going to happen is that they will void from the bladder into the vagina, and the hydrocolpus will fill, and then it will slowly dribble urine out all the time, but it won't necessarily empty the vagina. And because it's not emptying the vagina, the distal ureters will remain compressed, and it's the compressed distal ureters that cause all the trouble that we see.
There's another question, and from Dr. Fiana, actually. What about patients of longitudinal vaginal septum? How does CIC work in those patients?
Yes, that's a really good question. And it was something that we worried about a lot. But if you're passing the catheter up, it seems that randomly it goes one side and then the other. And we haven't had a situation where using CIC, we only drained one side. So you just pass the catheter up, and it seems like sometimes it goes one side, sometimes it goes the other, and that drains off both sides. We haven't had a problem with that. But obviously, if you're following on your ultrasound and you see that you're not draining one side, then that would be an indication that you would need to consider other options. And I think that's the key thing, is you've got to follow the patients and make sure that they're continuing to drain both sides. And if they're not, then you may need to consider doing vaginostomy or something else.
Thank you. And then there is a question from Dr. Naiman. He wants to ask about the role of urinary sodium levels in stoma patients.
Oh, sure. So if we think about the physiology, we know that our bodies make the content of the jejunum and ileum have a sodium content of 100. And the reason it does that is because that's the optimum level in which the little sodium glucose and sodium fructose pumps absorb sugar from the milk. And so if the body's sodium levels drop, then we're unable to do that, which leads to poor absorption of sugar and poor weight gain. What our bodies then do is they retain sodium in the distal loop of Henle in the kidney, which means that the urine has a low amount of sodium in it. So what we do is we test the urine for sodium level. And if the sodium level is less than 20 in the urine, millimoles, then that tells us that the baby is holding on to their sodium in their kidney because their sodium in their body has dropped. And that's the cutoff we use to supplement these babies with salt. And you can just add a little bit of salt to the milk, or if it's an older child, you can salt their food, and you can recheck the sodium in the urine in a week or two and see if it's going up. But it's actually really, really helpful to promote weight gain in children with colostomies. And I think it's an unrecognized reason why children don't gain weight. So the two common reasons that we can manipulate are acidosis, because reabsorption of urine, and low sodium because of sodium loss from the stoma. The acidosis you can treat by giving the child bicarb, and the sodium loss you can treat with giving the child sodium. So if they've got both, give them sodium bicarb. If they've just got low sodium, give them sodium chloride. But it's important that we monitor those things, because if the children are not gaining weight well, then I think their risks of surgery and complications with surgery go up. So, you know, this is planned surgery. So our rule is that the child always has to have positive weight gain prior to having reconstructive surgery. And if they're not growing well, you know, we try and do different things, get them growing, and that keeps the surgical complication rates. I think it helps to keep them down. Thanks for the question.
Then there's a question from Dr. Arshad, and he wants to ask about the role of laparoscopy in Cloaca, especially in terms of anal reconstruction.
Yeah, so I think it's really important, and we use it a lot. As I said, we used it on Monday for a Cloaca patient. I think there's a number of times when laparoscopy is very helpful. Number one, if the rectum's high, it allows you to free up the rectum without having to do a laparotomy, which I think is very helpful. A second time is sometimes when you scope the patient or you do your cloacogram, you don't get to see vaginal tissue. You can't find the vagina. And then you're stuck in the situation where you go, I don't know where the vagina is. And if you just go in blindly from below, you may inadvertently open the bladder neck in a place where you think the vagina is. So we find it's much safer in that situation to put a laparoscope in first and have a look and see what the vaginal anatomy is, to work out where it is. And in some cases, you're able to free up the vagina if it's blind ending in the abdomen. And we even, in several cases where we have to do the separation and it's high, we will do the separation of the urethra and vaginas with laparoscopy as well. And I think we can go into this in more detail when we do the next webinar on the technical piece. But my answer to your question is, I think laparoscopy is very helpful in the management of cloaca because it allows us to get more information to do safer surgery and not cause any damage. And that's always going to be our goal, and to give these girls the best possible operation, I think.
So Dr. Eli Baksh wants to know the ideal age for total urogenital mobilization.
I don't know if I can give you an exact best age. The way we think about cloacal reconstruction is that if there's any risk that you may have to do a vaginal replacement, we think that it's a little better to do that in a slightly older child because the blood vessels are a little bit bigger. So we try to avoid doing vaginal replacement in patients under 6 months of age. There's good data from the colonic interposition and esophageal replacement data that over 6 months they do a little bit better. So that's kind of what we've used as our rule of thumb. And so we just generally don't reconstruct the kids under the age of 6 months because we generally do our examinations just prior to reconstruction. And so we do them at 6 months, we do the reconstruction at 6 months. If the baby's smaller or they're not gaining weight well, we may put that out a little bit further and do it closer to like 9 or 12 months once they've shown adequate weight gain. But I personally prefer not to do cloacas under 6 months of age.
So Dr. Shazi has a question, and while making vaginostomy, taking tube vaginostomy out through midline versus off midline, does it make any difference?
I don't think it necessarily makes a difference. Your wound infection rates are always a little bit higher when you have either stomas or tubes in the wound itself. Remember, most of these children are colonized with bacteria in their bladders, especially if there's been a delay in presentation. So that would be one reason why we may want to take it off to the side just to reduce the risk of infection. But it certainly wouldn't be wrong to put it in the bottom of the wound. And so, I think you can do either. We've traditionally done it off to the side just to get it out of the way. So when you get into the pelvis, it's a little easier to get into the pelvis, but I don't think that's a must.
So Dr. Iftikhar wants to know about your experience regarding patients having associated cervix and vaginal atresia, and how would you manage those patients?
Yeah, thanks for the question. I think it's a really important thing to talk about. And again, I don't know if you want to talk about it today or you want to talk about it in the technical part, but just to touch on it today, you know, if you don't have a cervix, it's really hard to have a pregnancy in that uterine tissue because there's no way to really maintain a pregnancy. I will also say that it's difficult to always know whether the cervix there, especially in a very small child's structures. So if you're not sure that there's a cervix and you really can't tell from the anatomy, it might be reasonable to keep that structure in the pelvis and maybe use it when the patient gets older. However, if you're sure that there's no cervix, there's really no point to keeping that uterine tissue because it's never going to be able to maintain a pregnancy. So if we just see, like sometimes you see those tiny little nubbins of tissue where there's clearly no cervix, it's just a little lump of uterine tissue, we would remove those at the time of the reconstruction to prevent the need to having to do an operation when the patient's much older to go back and take it out. However, if you're not sure and you're in doubt, you may want to keep the tissue and see what develops when the child gets bigger and older, and then take it from there. We have studied whether MRI is helpful, and at this point, we don't believe MRI is helpful. But we can talk more about that next time when we do the technical piece.
So how would you manage cloaca with urethral meatal stenosis after birth? Do you advise genitoscopy at birth in obstructive urinary symptoms?
Yeah, so I mean, I think the patient needs to drain urine. So if you have no opening on the outside or a tiny opening on the outside, I think you've got to troubleshoot that. You might try and pass a tube to start with. You might try and use a very small scope if necessary. And if you can't drain that effectively, then you may have to drain it transabdominally with either a vesicostomy or vesicostomy and vaginostomy. And that does happen sometimes. You know, you get a patient where there's really very little opening on the outside and they can't drain urine. So I think all of the above are necessary. And like we said before, our goal in the newborn period is two things. Number one, to get the stool diverted. And number two, to make sure that the urine drains and that the kidneys are decompressed. Now that may be CRC, that may be a vaginostomy, that may be a vesicostomy, that may be a nephrostomy or ureterostomy. Whatever way we have to do to get the urine to drain and decompress the kidneys. My statement about CRC was that's the least invasive way to get the job done in a patient with hydrocolpos and dilated kidneys. But I think we have to have the mindset to move from least invasive to more invasive as we work to drain the urine. So if you don't have a good opening at the bottom, then you've got to make a plan to drain the urine another way. Maybe you scope it and put a tube in, maybe you do vesicostomy, maybe you do vaginostomy, maybe you do all three.
So we have a question from Dr. Ju King. It's related to surgical management. If you would like to answer it now, or we can ask it when we have other presentation. What would be your ideal choice for vaginal replacement, small bowel or vaginal switch procedure?
Okay, great question. I will deal with that, but just to answer quickly, I never ever do a vaginal switch. A lot of them were done in Cincinnati, and the gynecologist from Cincinnati looked at them and the results aren't good. So we don't do vaginal switch at all anymore. We use a bowel near vagina, and you can choose between small bowel and colon. My first choice is always small bowel, but I know there are other surgeons who like to use colon. I don't think it matters all that much. I just think that the small bowel doesn't produce as much mucus, and it also doesn't grow quite as much. One of the downsides when you do a vaginal replacement is when it's a little baby, you make a 5 centimeter or 6 centimeter neovagina. And then when you come back when she's 20, she's got a 20 centimeter neovagina. And it's really hard to do a pap smear on someone with a 20 centimeter neovagina. So that's why I tend to use small bowel, but there's no data out there that says small bowel is better than colon or colon's better than small bowel. But none of us that I believe are doing vaginal switch anymore.
Okay, so we have a question from Dr. Sumera. Have you ever experienced type 1 pouch colon with common cloaca?
Just say that again.
Have you ever experienced type 1 pouch colon with common cloaca?
Yeah, I personally haven't seen that. I know you get a lot more pouch colon in your part of the world than we get it in South Africa or in the States. We do see pouch colon here maybe once every second year, but not commonly. I have seen common cloaca with the bladder exstrophy, so not cloacal exstrophy, a cloaca with a bladder exstrophy, but I have not seen cloaca with pouch colon. But I think what you would do is you would use your pouch colon principles to deal with the rectum, and you would use your vaginal length and urethral length to work out what to do with the front. And that's why I said, when you look at these patients, think about the PC line and the rectal location and the length of the colon to work out what to do with the rectum part, and then use the urethral length and common channel length to work out what and how to reconstruct the anterior or urogenital portion, if that makes sense.
Okay, so Professor Dr. Muhammad Salim has a question. How to deal with patients of common cloaca and sacral agenesis regarding outcome in reference to continence?
So how to do common
deal with
cloaca
patients
and,
of yes. How to deal with patients of common cloaca and sacral agenesis regarding outcome in reference to continence?
Yeah, so sacral agenesis is a big problem. And I think, you know, I think long common channel cloacas in general have fairly, let's say, guarded fecal continence, especially when you get to sort of 5-6 centimeter common channel cloacas. And, you know, what we tend to do is, you know, reconstruct the kids. If they have normal, we think normal ability to walk, in other words, they're not going to be in a wheelchair for the rest of their life, then we think it's reasonable to close the stoma. If the patient is going to be in a wheelchair, like they've got an associated myelomeningocele or very bad caudal regression or something like that, then I think it's very reasonable to think about keeping a colostomy on those patients, because that makes it much easier to avoid sacral pressure sores and that kind of thing. I still think you need to do the reconstruction at the bottom, because you've got to separate the rectum from the urogenital tract. Otherwise, you run the risk of getting a lot of UTIs and stuff like that. So we would still do the reconstruction, would still put the anus where it should be and that sort of thing, but you may keep the colostomy in that situation. If the patient has the ability to walk, then, or we think they're going to be able to walk, then we would close the stoma. We would let them poop in a diaper like every other child does. And then when it comes time to potty train, we would clean them out with rectal enemas and bowel management. And we could talk about bowel management another time. And that allows them to be clean without necessarily being continent. And then at some point, you may choose to either do peristine or some sort of antegrade enema option like a cecostomy or an ACE or a Malone in order to facilitate the bowel management. But that's kind of how we think about it, even with sacral agenesis. Are they going to be able to move around? If they are, great. Then we would do the reconstruction. If they're not going to be able to move around themselves, then we would consider keeping the colostomy. I hope that answers your question.
Okay. So Dr. Mehreen has a question. How successful is urogenital mobilization? Is there any recurrence of urogenital sinus? How do you manage it?
Yeah, so I think if you stick to the rules, if you don't try and do a urogenital mobilization on anyone with a common channel of more than 3 centimeters, or a urethra of less than 1.5 centimeters, then we've been able to show that we can get them all to reach the bottom, and you shouldn't get recurrence unless you repair it under tension. If you don't repair it under tension, it should be okay. I think the problem came in previous times where people were doing something called a transabdominal TUM for longer common channel cloacas. And if you look at the older seminars papers from 2010, 2016, they would talk a lot about transabdominal TUM. And then you get into that difficult situation where it doesn't reach or it's under tension because you chose to do a TUM on a patient with a longer common channel cloaca. And I think that's where one gets oneself into trouble, because you can't get it to reach. And then you see techniques described like carving the pubis and all that sort of stuff. We don't advocate for that at all anymore. We really feel like you should only do a TUM in a patient with a short common channel less than 3 centimeters. And if it's more than 3 centimeters, you should leave the bladder alone and do a separation up front. And I'll explain that in great detail in the next talk. If you do get stenosis, then the question is going to be, what is the stenosis causing? If they're causing the child to be unable to void, then you need to deal with it now. If they get stenosis of the vagina, but they can still void normally with urine, you may choose to wait until the patient goes through puberty and deal with the vaginal stenosis when they've gone through puberty, in order to have better healing once there's estrogen around. But I think the key to avoiding trouble with the TUM is patient selection. And that's really what the talk was about today, was to help people choose the right operation for the right patient. Because I think the TUM is a very good operation, and it's relatively easier to do than the separation. But you got to choose the right patient. And I think one of the bad things that happened previously was, because TUM is technically easier than separation, we as surgeons use the TUM for patients who maybe shouldn't have had it used. And that's where I think we ran into trouble. So that's what the point of this new protocol is to try and do better patient selection.
So there's a question from Dr. Mosna. What is your view regarding post-menarche follow-up of vaginal reconstruction that has been done in early years? Does hormonal changes have impact on it?
Yeah, absolutely. So we would advocate for longitudinal care. We did a study here in Columbus where we showed, even with all our fancy stuff, we still didn't know the total anatomy of the gynecological structures in quite a big portion of patients. So what we do here in Columbus is that once a little girl has developed breast buds, we know that the brain and the ovaries are talking to each other. And so 6 months after telarchy or telarchy, we would advocate for starting to do an ultrasound. If the ultrasound shows us that they're developing an obstructed system, we would then follow that up with further imaging like MRI and work on trying to prevent them from getting obstructed menses. Because if they get obstructed menses, their risk of developing endometriosis is much, much higher. So we are quite preemptive with doing that. And we think that it's very important that all of these little girls get an ultrasound done within 6 months of having telarchy, which will then allow them to try and predict which ones are going to run into trouble and then deal with it at the time.
Okay, so I would like to invite Dr. Iftikhar Jan for his remarks on common cloaca.
Thank you. Hello, can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yeah, thank you so much, Professor Richard. And I think we are very much impressed for your work on this common cloaca anomalies. And I read your papers, and they are really, really very impressive. And your presence here today shows your interest in disseminating the knowledge to the other pediatric surgeons. And it was really a wonderful presentation which you did today, and I thoroughly enjoyed it. And personally, I learned many things, and I'm sure all the participants, they did get a lot of good information, and we are looking forward to your next presentation. And I also take this opportunity to actually, I think we should make a group. I should suggest that we should make a group where our doctors and young doctors and senior doctors who are managing cloacal anomalies, which is a very, very complex condition, to share with you and with the team so that they can suggest some management plans for these complex cases. So that will be a great idea if you can work on that. And our young man, Naeem Liaquat, is a very, very great, enthusiastic part of our member of our family. And we are very proud of him. And he is the one who is generating a lot of interest, and actually is the main person behind arranging a lot of these sessions. And I think he will be a key person to make this sort of a group. From my side, as you said, we don't see these cases very often where I'm working here, but in Pakistan, we have got many cases, and a lot of them, they don't know where to get their treatments, because not all the departments, they will provide treatment for these sort of cases. And I think Professor Salim is here. We can also suggest to have a group for anorectal malformations, and to make a dedicated team of people in Pakistan also who should now start thinking on those lines, because in the last nearly 10 years, pediatric surgery has moved forward in a very, very dynamic way in Pakistan. Our youngsters are very enthusiastic, and we have got now, I think we are at a position we can send people abroad, get them trained, and they can become the main trainers when they come back to Pakistan and start treatment of these complex cases. We do have an infrastructure in some of the hospitals, and people are doing a great job. But still, I think if we can make a team of people who is doing in each city, that will be a big service to the community. And all I can say is thank you so much, Richard. And really, there are no words to thank you for your this great presentation and contribution to towards improving services in the third part of the world. Thank you so much.
Thank you, Dr. Iftikharjan. Dr. Salim, can you please go for the closing remarks?
Thank you all for this great talk. I am really thankful to Richard, who gave a comprehensive and elaborative talk on the diagnostic workup of common cloaca. And we hope the next session, much more people will join us for the addressing this anomaly. Thank you again, all the participants, and especially Dr. Naeem for arranging such webinars. This series of webinars will go on, and we will we hope that our American colleagues will participate in this series of webinars by contributing and disseminating knowledge to the third world countries. Thank you all again.
Thank you, everyone. Thank you, Dr. Richard, Dr. Naeem, and Dr. Salim, Dr. Iftikharjan. See you in the next session. Thank you.
Thank you very much, everyone. It was a pleasure to be here.
Thank you.
Sure, sir. Sure, sir.